Hello, everyone. This is Nayiri from Low Carb and Fasting. We have a special guest with us today, Dr. Jen Unwin from the UK. Dr. Unwin, you are a consultant, clinical health psychologist, and we're very excited to have you on Low Carb and Fasting today. Why don't you introduce yourself to our audience who may not be familiar with you?
Yes, thank you so much. Thank you so much for having me. It's lovely to be able to talk to you. Yes, it's a bit of a mouthful, isn't it? Clinical health psychologist. So basically what it means is that way back in the distant past, I did a psychology degree, and then there's a specialist training for clinical psychologists in the UK that so to work with people around thoughts, feelings and behaviours in clinical settings, so usually in the NHS, obviously, adults, children, older adults, people with learning disabilities. But I particularly specialised in health, so that's why clinical health psychologist. So I worked most of my career in the NHS, in big hospitals. So I'm retired from the NHS now. I did 32 years, but I worked in big general hospitals and health teams and community health and so on, helping people to live as well as they can, sort of psychologically and quality of life with chronic health conditions, whatever those might be. So chronic pain, diabetes, lung diseases, and even life-limiting diseases like cancer, for example. So that was my background. And then, as some people will know, towards the end of my career and towards the end of my husband's career, because he's a GP locally, we started working together, and I brought what I knew and he brought what he knew to a project that's still going, which is helping people at his practice of 9,000 patients to have better health, but particularly those people with type 2 diabetes. That project has been going on about 10 years now, and some people may know we've written up lots of papers, we've spoken about it. If you Google my name or David's, it usually comes up with some video of us at some conference talking about that project, because people have been incredibly successful, and we've just celebrating, it's well over 100 now, 100 people who've put their type 2 diabetes into drug-free remission. So not only are they better and all their results are better, but they're not taking medication. And so, in our view, that's 100 people's lives improved, transformed, made a difference to. Yeah, so that's one project that I'm doing now. There's other ones that I'm sure we'll get into in the discussion, but I don't want to chat on for too long.
Well, we are going to bring Dr. David Unwin as well on the channel to tell us more about how he manages to put type 2 diabetics into remission or reverse their type 2 diabetes. He constantly posts about that, and I'm fascinated. I follow all of his sort of publications. Is what you do covered by the NHS, or do people pay privately for it? I've always been interested, but haven't been able to find out that detail.
Yeah, what a good question. Yeah, because more and more people know it's a possibility now, and more people are interested. So the work that I do with David is obviously just within his practice, so they have to be patients of his. There are other ways of accessing that sort of knowledge and information, and I've personally just starting to do some work with a new company that's starting up called Health Results. So it's healthresults.com, just getting going, with Campbell Murdoch, who's also a GP in the UK, who you've probably heard of, and some other people in the space. And there's going to be programs available, but also one-to-one consultations, both with sort of doctors, with psychologists, and but also coaches and the nurses. So that's it. That's an exciting new development, because I think people are interested in accessing not only the information, but also I think a big piece is the support. We can all have the information, can't we? We all know smoking's bad for us. We all know we shouldn't eat sugar, but it's actually putting it into practice where you sometimes need that coaching, that support element, and obviously with people with diabetes, either type 1 or type 2, there are medication management issues. So some people shouldn't go into it on their own. Yeah, so I think that's that's going to be a good step forward, really, for people who haven't got, because not all GPs know about this stuff yet. It's spreading, isn't it? Lots more do, and there's lots more GPs in the UK and internationally, and specialist doctors who know about this work and who understand it. But it's early days, so lots of people will have a GP who wouldn't understand how to support them through this journey to reversal, as you say.
Yeah, I've felt that. I mean, I've had no support, not from my GP, not even my diabetes consultant. He basically says, I don't understand how to manage blood sugar. So whatever you're doing, keep doing it. You're doing well. And I've had to learn through trials and errors, because there's no other way. There's no other support. They don't understand how to manage blood sugars through nutrition, through good diet, or even exercise.
Yes, and we have to keep spreading the hope that this is possible, because I think what happens is that a lot of professionals have got disillusioned, really, with giving dietary advice, because the dietary advice that they're taught and that they give is the same old advice that actually isn't going to help you reverse your diabetes. The Eat Well plate isn't designed for people with type 2 diabetes. It was sort of designed for the general population, and I think we could genuinely argue that it's not so great for that either. But obviously, I'm a psychologist, not a nutritionist, so I shouldn't say too much about that. But yes, I think I think that's right. We need to keep spreading the word, and it's a bit of a ground up revolution. Like, you're just such a fantastic example of that. There, people find this information wherever they find it, on the internet, or somebody sees someone else who's done it. It inspires them, and they do it for themselves. But then, like you, they get passionate about spreading the word, and we're trying to sort of rescue other people, and then they get passionate, and we all believe in it so much, and we've all seen the amazing results that people can get. Well, you get personally, but then that you can also help other people to get. And it's such a lovely field to work in. It's so rewarding. It doesn't feel like work. So I'm now working harder than I ever did every day in my retirement, but just because it's so rewarding to do.
It's I'm going to use the word infectious, but it is the feel-good factor about this lifestyle in general, the low carbohydrate lifestyle, which includes, I mean, for me at least, fasting and exercise, is so infectious. When people see that you're doing well, then their interest grows even bigger. Dr. Ami, tell us more about the message of hope, which I think is the greatest thing I've ever heard. The message of hope, which I actually put practice into, in the treat, which you incorporate in your practice, helping people overcome their food addictions.
Yeah, and changing behavior. So this all started. So my doctorate was I was very interested in how some people with physical health conditions do really well. So you might have a person who's got exactly the same, let's say, on a scan, exactly the same amount of arthritis, let's say, and there's two people who look on a scan completely similar physically, and they have all these sort of things in common. But one person will do really, really well and have a good quality of life, and they'll feel positive emotionally, and they do the things that they enjoy, and they have positive social relationships. The other person, feels a lot of pain, has to take a lot of medication, is sort of withdrawing from activities, their mood is low. Really, there can be a big difference in how people psychologically adjust, even when physically it looks like they've got the same amount of yeah. So actually, my PhD was actually done with people who were having lower limb amputations. So they were all having the same procedure done, and there was going to be the same amount of kind of physical disability, if you like. But I was looking at who coped well rehabilitated well and had a good quality of life, further down the line, and those who struggled. And hope was this big factor that made such a difference. And so for me, it was working out, right, okay, so understanding what this hope thing is, and then how do you, as a clinician, how do we help people to become more hopeful? Because obviously that's going to be some magic dust. So, and I think this is something that people sort of intuitively understand and they believe, but it's not many no doctors would have training in this or know how to incorporate that in their consultations. So that's what I was trying to work out, was how could I help David, who's a GP, sprinkle some of this hope magic into his consultations, so that he wasn't just giving people the right advice, which was around reducing carbohydrates if your body can't cope with carbohydrate. The good advice is to reduce it, but how can you, that's really simple, isn't it? But it's not easy. It's not easy for people to change their behavior. So and some people will, like you. So I'm guessing you're quite a high hope person. You're probably a person who likes to set yourself goals, likes to be organized. I'm only guessing. Will sort of set say, I'm going to do, this is my next step. I'm going to do that, all because, I want this better future that I can see if I do those things. So that's the sort of definition of a hopeful person, someone who sort of has a sense that there's something that there will be better in the future they're reaching for, that they can sort of see the steps to get there, if you like. But not only could they see the steps, but they also have the motivation to take the steps and then review and see how that goes and then take the next step. So how do you sort of incorporate that thinking, or how do you facilitate that kind of thinking in a clinical scenario where you're trying to get people to really change their behavior? So going low carbohydrate in the world that we live in is it's challenging. So the advice is simple: cut down your carbohydrates and sugars, ultra processed foods. It's like one message, isn't it? But how do you actually, what are the steps? How do you get people to take those steps? And so there's a few components to it. So and the model I came up with that was easy for David to remember, and we've written a paper about it, which is open access, so we can link that in your show notes for people to have a read if they're interested. And also you will see, as I say, if you Google us, there's a conference at Low Carb Denver where we did a demonstration of it and talked about it. So the model is called GRIN, and that's to help people remember the simple stages and to sort of incorporate those in their consultations. But you can also use it on yourself or in conversations with other people in the family. It's a sort of universal way of trying to enhance motivation and hope and positive thinking that you can use in any way you like. So the first is that the importance of having goals. So having a conversation around, what are your best hopes, in 6 months' time, or if you had any, if we could sort of wave a magic wand over your head and your health was so much better. Say we're talking about health. What would that look like for you? What would good health look like for you? Or if you had any health goals, what would they be? If life was better around your health, what would that look like? So a way of sort of asking about that. And people often come up with, well, I'd like to be able, so often people say, I'd like to lose weight. That's a really common first answer. And that's fine. It's a great goal, isn't it? But it's not, you need to sort of dig a bit deeper. So I might follow up with, well, if you lost weight, if you lost a significant amount of weight in 6 months' time, what would be better? Because really you're trying to get a sense of how would life be better. So you could be, any kind of weight and still not have a life that you're sort of very happy with. Weight isn't really the one metric that we're interested in, although it does help people obviously to do the things that they want to do if they weigh less. So what would be better? And then people often say things like, in David's practice, things like, well, I'd be able to play football with the grandkids, or I'd be able to go walking with my husband now we've retired and I've just, my knees hurt too much, or I'd be able to breathe better and, get up and down stairs. Whatever it is, they'd have some sort of a sense of a future where things are better. That's what you're trying to get at to. So that's G for goals. And then R, so the R of GRIN is for resources and resilience. So then when we've got an idea of where people want to get to, say it's about playing football with the grandkids, and improving their health, losing some weight so that they can get there, then we might say, well, what you want to know is what's already working or has worked in the past, what they know about possibly getting to this future, what's working, what's worked in the past, what their personal kind of characteristics are that might help them. So like, so for you, I was saying, well, I guess you're quite a hopeful person already, or you're probably quite goal focused. So what are their personal characteristics? Are they an organized person? Are they a determined person? Have they got through difficult stuff in the past? Have they lost weight in the past? Other resources might be, well, who's around? You're sort of kind of exploring what's already on their side. Is there anyone else in the family who, either already has good health or is hoping to improve their health that you might do this with, or a friend? Is there somebody around that's going to support you? So what's on your side? So exploring all the resources and the things that are already going well or have gone well in the past. So you're kind of increasing their sense of likelihood of success, their confidence. People tend to focus always on the problems and how bad they are at stuff, and they should have done this and they haven't done that. And you're trying to encourage them to focus on times they've been successful in the past, what's already going well, because that increases their confidence about taking these next steps. And then I is about the next step. So I is for increments. So it goes goals, resources, increments, because you can only start where you are and take the next step. That's how you climb a mountain. There's that thing about how you eat an elephant, one bite at a time. Sometimes people still feel so overwhelmed. They've failed so many times. It seems like a massive task. We've had people who had an enormous amount of weight to lose, or were on lots of medications, and incredibly unwell. So it's always about where are you now and what's the next little step. So if they want to get to this point of playing with the grandkids and they're already able to maybe walk around the block with the dog, or they go to the gym once a week already, they've maybe lost a lot of weight in the past with some other scheme like Slimming World, and you can explore, well, what of that did work well that you think you could go back to. So and what's the next little step? You might ask them that, and they might say something like, well, I really can't moderate bread. It's a really common one in the practice, is like, they just, if there's a loaf of bread, they'll just eat half a loaf, a whole loaf. They can't just eat one slice. So we might say, well, what you feel your next step is, and they might say, well, I need to give up bread or biscuits or whatever it is, or I need to join the gym, but the point is, you're not giving people advice, and you're not saying, I think you should give up bread. You're saying, what are you going to do next? Okay, so it always comes from the person. It's always led by them, because if they come up with it, more than likely they're able to do it. Whereas if you come up with it, you have no idea if they're able to do that as a next step or not. So increments is the next little thing. So what's the next tiny step towards this place that you're hoping to get to? And then the fourth is N. So GRIN, and N is really powerful. It's noticing. So it's both you as a clinician noticing what seems to be going well, or if they've lost some weight or whatever it might be, but also them noticing improvements. And one way that we do this in the practice is also getting people to take some kind of measurement. So it may be a weigh-in. It might be I've got one here actually. It might be tape measure around the waist, you know, if they prefer that, and that's super easy. I mean, you can't get any easier than that. It might be how far they can walk without getting out of breath. You know, it can be very personal. It could be their HbA1c, whatever it is. But not just the measurements, but also noticing questions about, you know, well, you gave up bread this week. That's amazing. You know, what have you noticed? How have you felt? You know, and people will usually say, oh, well, you know, I've my indigestion's gone, or I'm sleeping better, or, you know, my wife said that I'm less sleepy, or whatever it is. It could be anything, but just an exploration of what's working, really. So that's GRIN, goals, resources, increments, noticing. Doctors get it, they can do it. It's super simple, and it's just a way of keeping that conversation on track.
Fabulous metric, I would say, if we can call it a metric, but noticing is so important. Noticing every little step, every little improvement, and because that can only reinforce hope, I think, right? People become
That's
more
the hope.
hopeful.
Exactly. And it's, again, it's a virtuous cycle. So noticing something, they take a step which they came up with, they notice some improvement, it's a little bit of success, and that does breed success, and counteracts this hopelessness, and then take another step and another step. Yeah.
Fabulous. It's the first time I'm hearing about it. It's educational for me as well. What was your personal journey into the low carbohydrate sort of space?
Yeah, what a great question. Well, yes, looking, so all my life I've had food issues. I was a foodie from my first memories. My first memories are of food. I always loved food. If there were sweets or carbohydrates, I was first in the queue. um, yeah, I was really very drawn to such things, and I think that's the case for many of us with these sort of sugar addiction-y, food addiction problems, that actually we were kind of born that way. And I think if I look back, my mother was certainly the same. So I don't think it was even that I learnt it off her. I think I learnt all the crazy dieting behavior off her, but I don't think I learnt that sort of natural tendency. I think it was just something that we both shared, really. So yeah, so I had understandably a lifetime then of, because I didn't like being overweight. I would try diets, lose weight, but then fall off the wagon because these diets are all unsustainable, aren't they? I did all the crazy shakes and whatever was the latest thing. I did it, put the weight back on again, up and down, up and down. And then about 10 years ago, I read a book called Escape the Diet Trap by Dr. John Briffer, who's also a UK GP. And it was basically about low carbohydrate. When I read it, because of course I was thinking I do want to escape the diet trap, definitely. So I thought, I'm going to read this book. And he talked about low carb, and that was the first time I'd really heard about it and the benefits of it. So of course I thought, right, I'm going to have a go. I went, because it's my character, to go feet first, cold turkey into anything. And I wasn't on any medication, or so that was okay. So yeah, obviously just a note to people listening that don't do that if you're on diabetes medications or high blood pressure medication. Go and check with your healthcare team first. But I wasn't, so feet first. Felt ghastly for about a week, like tired, headache, keto flu. But on about day 8, which he'd said in the book would happen, the angels were singing, the lights came on, and I felt really fantastic. I felt energetic, cheerful. You know, I was sleeping well. I was like, this is a miracle. So yeah, so that was the start of it, really. And then what happened was, obviously David and I started thinking, well, we could work together on this project with his patients. So his patient population were getting sicker and sicker, more and more overweight, more and more diabetic in the 30 or so years that he'd been working there. So we thought, right, let's have a go. I did the psychology bit and obviously taught him, you know, the GRIN model, and we worked in groups. I think groups are incredibly powerful, and again, most doctors don't do it, but it's wonderful, the support that people give each other and the hope that people get from seeing other people make progress and do well. That's like an added factor, if you like. They see their neighbours losing 4 stone and reversing their diabetes, it's incredibly motivating for them. They feel they could, if George can do it, so can I. So we ran groups, and we've been doing that for nearly 10 years now. And we've been learning a lot about how to keep supporting people, how to help people who struggle more than others, who fall off the wagon. And that whole food addiction, sugar addiction piece is so relevant for some people. And fortunately, because that was me, I could sort of understand it. And then since I retired, I went and did extra training on this topic, and I'm really immersing myself in it now. I trained with Bitten Johnson, who's the sort of international clinical expert on this, and we're still working together. And together with Heidi Yever, who also trained with Bitten in the same cohort, we've set up a study looking at group support for people with food addiction. So we're doing that sort of under the auspices of a public health collaboration. And we're also, in October, actually, we're running an intensive weekend for people with food addiction. And I'll also be offering one-to-ones through the Health Results website that I was telling you about before. So yeah, I've got super interested in that, because there are a proportion of people who really have a lifelong struggle with moderating sugars, grains, and ultra processed foods. And it's so much like like any other addiction, really. It's really hard for them to stay off them, but they feel much better when they do. And obviously there's an overlap sometimes with people who've got type 2 diabetes, for example. That they're finding it hard to stay stopped from sugar and carbohydrates, and that's why they've got to the point of damaging their own physical and mental health, really. So yeah, so that's the story for me. And obviously, having put my own, I didn't ever have diabetes, but put my own weight problems and food addiction into remission now.
So when we're talking about food addiction, we're specifically talking about processed foods. It's not broccoli or steak, is it? Sugars and grains. Is that correct?
Yeah. Sugars, for most people, sugars, grains, ultra processed foods. For some people who are sort of what we say, sort of rock bottom food addicts, who've maybe had struggled for a long time, there can be other foods. So this doesn't apply to everybody, but for some people, and it did apply to me, some real foods can cause cravings and overeating. Like cheese is one, and you often see that dairy, for people who've done keto and low carb, if they're still struggling to lose weight, or if they're still struggling with food cravings, usually dairy is the next thing to look at, because it's really easy to overeat. It's so delicious. And also it's highly calorific. And the other one can be nuts. Roasted and salted. They often make people with food addiction problems kind of go completely crazy. The other things to be careful of are anything else that has a sort of acts in the same way in the brain. So alcohol, food addicts have to be really careful with alcohol. Even if they, like me, they didn't have a struggle with alcohol. I never did overdrink, because it wasn't something that I ever did. But if I ever did have a drink, I would be much more likely to then fall into going and having cravings for other foods and feeling much hungrier and kind of low mood. And it didn't trigger me to drink more, but it would trigger me to eat more. So alcohol was another thing. And yeah, anything that sort of acts in those reward centers in the brain, if you've really sensitized them by having a food addiction problem, they can, it's like it's like any addiction can be replaced by another addiction. That's why you see that people who've had a serious alcohol problem and they give up alcohol, they often turn to sugar, and will end up putting on weight. And it's the same with people who've given up smoking. it's a common finding that people who give up smoking tend to put on weight because they're trying to get their dopamine from somewhere else. So that's something to be really aware of. You know, it's this kind of whack-a-mole thing that you give up one thing, and but your brain's still looking for that fix, so it tries to find it somewhere.
Do you see any of your patients who probably struggling with sugar addiction, specifically sugar addiction and replacing sugar with artificial sweeteners?
Yeah, great.
And do we still call it addiction if they've replaced the regular sugar with, say, I don't know, something else, I mean, xylitol or whatever it may be?
What a great point to raise about sweeteners, and I probably should have mentioned about that. So on the whole, sweeteners are not a good idea if you've got a food addiction problem, because they just keep that that sweet thing going. Also, I've just seen a paper this morning that's someone has highlighted on Twitter, which actually shows that for women and for people who are obese, like we actually have a sort of neural response to sweeteners that causes overeating and cravings. So, you know, even though they're 0 calories, they're not neutral in the sense of how you're going to be responding to foods. And a big mistake that people make, and I made when you're doing low carb and keto, is to start doing the whole keto baking thing, where you think, oh, you know, I'm keto, so I'm going to have almond flour and sweeteners and butter and make this amazing kind of cake. Well, you know, I still couldn't moderate that. I would still, you know, I could eat the whole thing, or these little fat bombs things with sweeteners. So of course it's individual, and if people can kind of do okay on sweeteners and they're getting the health results and the weight loss results that they want, and it's working for them, fine. But you just be mindful that, you know, at the end of the day, most sugar addicts will have to give up sweeteners because they won't manage moderation very well at all with those sorts of foods. Yeah, and I just reminded me to say, yeah, the, like you'd said, that, you know, broccoli and steak, they're not binge foods for sure. Some food addicts do find it. There's a thing called volume addiction, where even when you're keto and low carb, there's still that it's still possible to overeat. You know, that overeating is a sort of process addiction that some people do get into. But I mean, there are things you can do about that, and some people end up sort of weighing and measuring things. That's one solution. Other people, so I'm one, I just eat one meal a day. That's how I kind of moderate my intake, because I can eat a pretty big meal actually. So today I'm going to have, after we finish speaking, I'm going to go and cook it up: two ribeye steaks and some roasted Brussels sprouts cooked in with some bits of bacon. Delicious. You know, that's great, and it's enough. It's all nutrient dense, and it's enough protein for the day, and I'm completely fine with that. I don't eat in the morning because I'm not hungry. I prefer to eat at lunchtime because I'm hungry at lunchtime. I don't want to eat 2 meals a day because I end up putting on weight, and I don't sleep as well if I eat later. So it's just what suits me and what I found through, in a way, going around that GRIN model. You know, what did I notice? When did I feel most well? You know, fewest kind of cravings and thoughts about food. It just works really well for me, this one meal a day in the middle of the day.
I love doing one meal a day myself. I alternate between 2 meals and 1 meal, but I skip breakfast. In fact, I always joke to my friends saying that the last time I ever had breakfast was probably 1999. So, and it's true. 21 years I've not had any breakfast, and I've gone against my GP's advice, I have to say. So then I learned to shut up and say nothing, because my GP said, "Oh no, you're diabetic. You must eat something. Have a protein bar."
Yeah.
I was wondering. In fact, the protein bars we know are actually carb bars. They're full of sugar but that was
all kinds of things. Yes, sweeteners, sugar. You know, probably seed oils. You know, really the message is for people with food addiction problems. Yeah, you've got to stick to real whole foods. So meat, fish, eggs. above ground veg. You know, it's kind of I suppose you describe it as a sort of clean keto, really, because you're trying to cut out the sweeteners and you know, be careful with dairy and nuts and things like that. So you're not having things like nut butters. You know, those people can really overeat those so
Oh, they're
easily.
delicious.
I had to ban peanut butter completely from the house. I couldn't have it in the house because I would just like, it was like crack cocaine. I used to just eat it out of the jar, and you know, that was what you know. The thing is, we feel like we ought to be just in control of our behavior, but some of these foods hijack that dopamine center of the brain, that survival part of the brain, and that's going to push you around. You know, even though we're clever people, we're sensible, we know we don't want to eat those things. If they're in the house, you're going to, and you know they're there, your clever brain will find a way of making you eat them despite your best intentions. So it's not about, that's what I learned really. It's not, and you know, I used to think, why can't I just control myself? It's because of that, because of this primitive part of the brain. So control your environment, get those things out of the house. You know, try not to go to places, particularly in the beginning, try not to go to places where all your favorite foods are, until you get a bit stronger and a bit in the habit of saying, you know, they're not the kinds of foods that I eat, because we can be triggered so easily by the environment. If we see something, someone else is having it, if we hear, you know, we hear it or we smell it, the brain can just, you know, get you, overtake you. And that's why we all fall off the wagon. It's how we kind of learn that. So you know, we try and talk to patients about, there's no such thing as a mess up or a failure. It's just that you've learned something new. You know, you've learned that actually it's not a great idea for you to go to McDonald's, or you know, or you know, you can't you're kidding yourself if you think that you can have that peanut butter in the house and not eat it. I had to, several times I would go out and buy it again, thinking, right, this time I'm just going to have a little bit, and it just never worked. And if it never works, be honest with yourself. Be brutally honest. Have I ever been able? Has it ever worked out well that I did that? No.
Unless, of course, you're short like me. I'm a short, small person. So I put my peanut butter jar on the top shelf in the kitchen, which I can't reach. I have to bring a chair or something to step on, which is too much of a hassle. So I don't access it. It's right there if I ever need it. But I don't see it. So I don't remember it. So it's gone. It's out of sight.
That's a great technique, and I think that's right. You know, either just don't buy it at all, or you know, maybe put it out of sight. Have a cupboard that someone else has got the key to.
Yeah.
You know, you have to trick yourself. You have to plan, and you have to get your brain in order by making these small changes. That's great.
And for me, it wasn't the food addiction which I was trying to overcome, but it's the effect on my blood sugars, which I think many diabetics will have noticed, especially if they're wearing a CGM.
I think a CGM is absolutely powerful because you get that instant noticing. So you know, where people have had a trial of the 2-week CGM and they've tried different foods, they can absolutely get that feedback. They see the numbers go high, and we're all a bit competitive, aren't we? So we want our numbers to be, we love it when our numbers are good. So you know, then you can see what can they eat, and the numbers stay good for them. So I think it's an absolute game changer. And I think whenever Apple come out with this watch that's supposed to do non-invasive, you know, if they manage to do it, I think it'll be an absolute game changer.
Did you wear a CGM at all, especially at the beginning?
Not in the beginning. I have done it as an experiment once or twice, because mine isn't very dramatic because I never was diabetic. So David wore one, and he has quite a dramatic. Few years ago, he put all the results on Twitter, like when he ate a banana or when he had a bowl of porridge, and I mean his would go up to 11. He went pretty sky high. I think he was never diagnosed, but I think he was probably on the way to type 2 when we went low carb 10 years ago. his blood pressure improved massively, and he needed a lot less sleep. I think he metabolically he was more on the runway than me. And I think we were just talking about it this morning, that often what happens is that those of us who can put on weight easily remain more metabolically healthy, because what insulin's doing there is pushing the sugar into our fat cells, and that's what would happen to me. The minute I sniffed some carbohydrate or sugar, I would just put on weight. And we've, as I say, we've had people, we've got one lady who's lost 9 stone. So and some of those very heavy people weren't actually diabetic. They just got, the way their body worked was they just got super fat. The sugar wasn't in their bloodstream because their insulin was working and doing its job. Other people who were normal weight, or even slightly underweight, can have type 2, and that's because when they get a high blood sugar, the insulin isn't working and the sugar just remains in the blood, or is messing up their livers and their pancreases. So again, it's an individual thing how people respond.
Yeah, CGMs are fabulous. I wouldn't be able to manage my diabetes as well as I do without my CGM. Now, your book. Tell us about your book, Fork in the Road. I'm very excited. I've ordered it on Amazon. I can't wait for it to arrive. There it is. There it is.
There it is. So yeah. I wrote this in lockdown 1 because I had a bit of time, because we had loads of things cancelled. We were supposed to be going all over the place, and then we had things cancelled. And I said, I think I'm going to write a book. So this is everything that I've learned to date about food and sugar addiction for people. And it's supposed to be written, it's really accessible. It's the book that I wished had existed when I was a teenager, because I would have completely understood it and been able to implement it. So it's that sort of level of advice. There's, recognizing if you do have this problem with food addiction, and describing all the symptoms of food addiction, and you can give you this sort of screening test. And then I incorporate these ideas about GRIN, like, so what will a sugar-free life look like? What are you hoping for in the future? What do you know about yourself that's going to help you on this journey? We do talk about food, so there's recipes in it, and there's all the food lists are like, these things are probably going to be fine. These things like nuts and dairy, you want to just watch it, or have some strategies like putting them on the top shelf, or weighing those things out, or you're going to have to cut them out. And then all the no foods that for most people you're not going to be able to moderate. And then we talk about really like the long term. If you're taking away food as this sort of way of getting your dopamine and your feel good neurotransmitters, what are you going to replace that with? How are you going to protect your recovery long term by building a sugar-free life? What would that look like? And for example, talking about, if you want dopamine and serotonin and endorphins, movement and exercise is one of the best ways to get that. And often people who've really struggled with their food and their weight have just completely given up on all of that. So it's not about exercising to lose weight, it's about exercising for your mental health and the benefits that it brings, sort of brain wise, really. So encouraging people, and hobbies and socializing and all of these things which can really about how do you want to live your life if you're going to be free of these chains that have sort of held you. And then we talk about how do you do it in the real world, so things like parties, restaurants, birthdays, holidays, and there's a lot of my lovely colleagues in the space. So David's written the foreword, but Bitten Johnson and Dave Wolf, Anna Fruling, Georgia Eade, who's a psychiatrist from the US, have all given me little tips and their own little tips and comments. So those are throughout the book, to see that it's not just me who's giving this advice, but these international experts. And some of the recipes are from Katie Caldesi, that people all know. David and I have helped them with their diabetes cookbooks, and so she's given us some recipes. And the graphics are absolutely beautiful. They were done by Michael Rowley and Kiki Johnson in the States. And the profits from the book go to the Public Health Collaboration. They don't go to me, and they're going to help fund this work that Heidi and I are doing with the group program. But also we're putting on a conference next year, May the 20th, and it's going to be linked to the Public Health Collaboration conference. So a one-day conference on food addiction. So keep an eye on the Public Health Collaboration website, www.phcuk.org, for information about that. But you've got the date there. Yeah. So that was the book in a nutshell.
That's incredible. You only just this morning, I think, posted one of the recipes from the book, and they all look great. They're great recipes, nutrient-dense foods, and things that people can make at home.
Yeah, that's what most of them are things that I eat on a regular basis and have sort of worked out. I don't like to complicate life, so yeah. So the chicken curry recipe is about the simplest you can get, but it's absolutely delicious. They're just really simple recipes that you can, it's not about being on a diet at all. It's really a lovely way to eat, and you should enjoy your food, and get that nutrient density. And these are the best foods in the world: meat, fish, eggs.
That was the one I saw this morning with the chicken curry. Of course, there's no rice with it, with roasted cauliflower, I think it was. It was amazing. It looked great.
Yeah, roasted cauliflower is really tasty. So just make some ghee at home, and the recipes for that's in the book as well. And if you just roast some cauliflower florets in ghee, or we do tender stem broccoli as well in the oven, it's absolutely delicious.
Okay, so fasting.
Okay.
Do you use fasting as an effective sort of way to help people win people off their addictions? Does it help?
Right. So fasting. So in the early days, on the addiction side, most practitioners, and I'd be with them really, wouldn't recommend fasting from the beginning unless you're already doing it. So like you were a person who didn't eat breakfast anyway. If you're already doing it, obviously you're not going to add unnecessary meals in. Kind of go with your hunger. So the early day recommendation is really to get that food plan stabilized. You might need to eat breakfast, lunch, and tea with your proteins and your fats. Just to, because otherwise you might get too hungry, too cravey, and then you're going to make bad choices. So definitely not in the early days. And then some people, if that works for them, and if they can maintain that and they've got all the results that they want, absolutely fine. Other people do like to do a bit of intermittent fasting because, like me, it just kind of suits you. But I think for food addicts particularly, you have to go a bit carefully. We've definitely talked to people about it in the practice, the type 2 diabetes people, particularly those with high morning blood sugars. I mean, why would you eat? You don't need to eat if that's the case. So we have talked to them about that, because a lot of people have had that message, like you said, that, you must have breakfast, the most important meal of the day. There's no logic to that, really. So that's definitely been recommended to the patients in the practice. And then we also talk to them about an eating window, and that it's not great to eat super late at night. And also, why do you need food? You're just going to bed, you don't need any fuel. So trying to bring your tea earlier, and maybe have your lunch later. And then for some of them have adopted one meal a day because it suits them. So we really let people decide for themselves and experiment for themselves. And as I say, obviously it's worked for me, one meal a day, but there are a lot of people in the addiction space that prefer 2 meals or 3 meals. But we definitely talk about not snacking, not grazing, not, because that keeps you constantly thinking about food. So yeah, just to get it only eating at meal times is that's a really good thing to do.
Great. Low carbon fasting work for most people. It works for me. Well, thank you so much for joining us today. I really appreciate you making the time. I'll put all the relevant links in the description, and I'm looking forward to talking to you again, hopefully soon.
Yeah, thank you so much. Thanks for your time.
Thank you. Bye-bye.